Hi, I'm MDean. I'm in nursing 7116, and today I'll be doing a full head-to-toe physical assessment on my patient Cindy here. It's my mom. So we'll start with making a general statement about her appearance. She appears to be healthy, well-nourished, appropriate weight and height. She appears well. So now we'll take her vital signs. I'll start by taking her blood pressure. Let's see. So I will locate her brachial pulse and then make sure it lines up there. So her blood pressure is 118/72, which is a very good blood pressure. Let's see. Next, I will assess her heart rate using her radial pulse. I'll count for 15 seconds and then multiply that to get her heart rate. Alright, so her heart rate is around 80 beats per minute. Next, I'll assess her respiratory rate. I would really try to do this inconspicuously, but for this purpose, I'll assess her for 15 seconds and then multiply to get her rate. Alright, so she's breathing at about 14 breaths per minute, which is appropriate. And finally, I'll take her temperature. And her temperature is 98.6. Okay. And then I would also assess her oxygen level. So I'll get my pulse ox here. And her oxygen level is 97%, and this also says her heart rate is 80 beats per minute. And I would also usually assess her height and weight. Fortunately, this patient knows how much she weighs and how tall she is, so we have already calculated that. Okay, we can pause. Okay, so now I'm going to do the assessment of the head. I'll start by inspecting and palpating her skull. I'll start at the frontal lobe and work my way back toward the occipital lobe. I'm palpating for any tenderness, any abnormal shape. And while I'm doing this, I'm also assessing her hair, the texture and distribution. Her hair looks very evenly distributed in its appropriate texture. If her hair were very coarse and dry, that could be indicative of hypothyroidism. And if it were very oily, that could be indicative of hyperthyroidism. So I'm also going to just assess her face. You can open your eyes, and I'm just looking at her, and I'm looking for any abnormal movements. I'm assessing for symmetry. If you smile, everything's symmetrical when she smiles. So finally, I'm going to palpate her frontal and her maxillary sinuses for any tenderness. Do you feel any tenderness? And tenderness could be indicative of a sinus infection as well. Okay, so next we're going to be doing the assessment of her ears. I'm going to start by inspecting the auricle of each ear, just for any nodules, lesions, just general hygiene. I'll do both sides. Are you feeling any tenderness in your ears?
No tenderness.
Okay, so I'm also palpating. I'm going to palpate your mastoid process. Do you have any tenderness in your mastoid process?
No.
Okay, good. Now for the otoscopic examination. Make sure my light's on. So I'm going to pull your ear up and slightly back, and I'm going to look into your ear canal. Once again, assessing for general hygiene. Any cerumen buildup, discharge, redness, lesions, foreign bodies. Some surprises. I'm looking for the tympanic membrane to be pearly gray, and I'm also looking for the cone of light. Just like on both sides. Awesome. So, next I'm going to do the Weber test. The next two tests, I'm going to use this tuning fork. So for this test, it's a Weber lateralization test. I'll place my vibrating tuning fork in the middle of your head and ask you if you can hear the sound equally on both sides.
Okay. Sounds equal.
Equal on both sides. Okay, that's good. If it were heard more on one side or the other, that could be indicative of conductive or sensory neural hearing loss. So the next test is the Rhine test. This test compares air conduction to bone conduction. So for this test, I'm going to place my vibrating tuning fork against your mastoid process, and tell me when you stop hearing the vibration. When you do, I'll move it to in front of your ear and tell me when you stop hearing it.
Okay. Okay.
And tell me when you stop hearing.
I don't hear it.
Okay. And that's great because the air conduction and bone conduction should be at a 2-to-1 ratio. So she should hear the sound for twice as long as she felt it. And I would repeat this in both ears. And now I'm going to test the acoustic cranial nerve, which is cranial nerve 8. This is going to be a whisper test. I'm going to whisper something to her in her ear, slightly behind her ear, and ask her to repeat that for me.
The dog chases the ball.
Okay, other ear.
I like your earrings.
Okay. And that concludes the test of the ears. Okay, so next we're going to look at the nose. I'll first palpate around her nose for any tenderness. I'm going to use my pen light to look into her nose. I'm just inspecting the mucosa, and I'm also determining the position of the septum to make sure it's midline. So I'm going to get you to look up a little bit. Look into your nose. Everything looks good, and your septum is midline. Next, I'm going to assess patency of the nares as well as the olfactory nerve, which is cranial nerve 1. I'm going to ask her to occlude one nare, and then close your eyes. So I'm going to get you to take a deep breath through that nare. Make sure you can get air in and out. It feels okay.
Feels good.
And now tell me what you smell.
I smell cinnamon.
Cinnamon, perfect. And then if you can occlude the other nare. And tell me what you smell here.
Alcohol.
Okay, so you can do that. So her olfactory nerve is intact. Okay, so now we're going to inspect the mouth. Using my gloves, I'm going to palpate for any abnormalities around her lips. I'm also going to use some gauze to palpate her tongue, and then I'll be using my tongue depressor and my pen light to look all around her oral mucosa. I'm going to displace the cheeks to view the membranes on the side. I'll be looking under her tongue because we know this is the most common site for oral cancer. And then I'll also be looking at her hard and soft palate, assessing for any jaundice. And then I'll also assess her tongue for symmetry, color, all that. So let's start. I'm going to start by palpating your lips. I'm going to get you to stick your tongue out for me. I'm going to palpate for any nodules, which I don't feel any nodules. I'm sure that's really dry. So I'm going to use my, what I call a popsicle stick, tongue depressor, and go ah for me. Okay. Awesome. I'm going to displace your cheeks right here and look on the side. Now this side. Wonderful. I'm going to look at your hard and soft palate. I don't note any jaundice. And we'll get you to lift your tongue up so I can look under. I don't see any lesions or abnormalities down there. Now for the testing of the hypoglossal nerve, which is cranial nerve 12, I'll be testing the movement of the tongue. So I'm going to get you to stick your tongue out. Move it side to side. Awesome. So her hypoglossal nerve is intact. I will now inspect the teeth. I'm inspecting for any missing teeth, decay, plaque, cavities. So I'm going to look through your teeth, which I kind of already saw, but I'm just going to look a little closer. And I can tell she has had some cavities filled, but I don't see any new issues right now. Okay. I did that. Now for cranial nerves 9 and 10, when I had her say ah, that was assessment of her glossopharyngeal and vagal nerve, which we test together. I did notice that her uvula rose midline. It was intact. And then to further test the vagal reflex, we would do a gag test, which we won't do for nice pupil purposes. But we would use the tongue depressor, have her say ah, and swab the back of her throat, kind of like with a strep test, and see if it elicited a gag response. Okay, so now we're going to look at the eyes. There's lots of cranial nerves to assess in this one. But first I'm going to start by inspecting the eyelids, eyebrows, conjunctiva, sclera, cornea, iris, and pupil. So I'm just going to look at her eyes. I'm going to assess your eyebrows for shape, your eyelids. There's no swelling, puffiness, discoloration. They seem equal. Your eyes appear to be bilaterally intact. Yep, perfect. So now I'm going to test cranial nerve 2, which is the optic nerve. In order to do this, I'm going to test visual acuity and visual fields. I'm going to ask my patient to put on her glasses because she does wear corrective lenses. Then I'm going to ask her to cover one eye, read a sentence from this magazine, and then cover the other eye and do the same.
Once again, I was in Africa, backtracking an elephant from Squatter's Field within a forest reserve.
Okay. Switch eyes.
You can do a different sentence if you
Yeah,
want.
Not long ago, Camp Fire netted each household in one northern district a check for $200, an amount regular to the average annual income in Africa.
Perfect. Okay, so her corrective lenses seem to work for her. Now I'm going to test the visual fields, which is also part of the optic nerve assessment. I'm going to ask you to cover one eye. I'm going to stand. Well, I'll stand right here. Nope, this is weird. Okay. I'll go right here, and I'm just going to ask you to tell me when you can see my fingers in your peripheral vision. They're going to be wiggling. So.
I see them. I see your fingers. I see your fingers. I see them.
Okay, now let's do the other side. Glasses are forming.
Mm-hmm.
And when?
I see it. I see it. Okay.
And last one.
Okay.
Okay, so peripheral vision is intact. Hold on. Okay, so now we're going to look at the pupils. I'm going to use my pen light. First, I'm going to inspect the size, shape, and quality of her pupils, which I actually already looked at her eyes and saw that they were equal, appropriate size. I would say about three millimeters. Okay, so I'm going to use my pen light to look. I'm going to be looking to see that they're equal, round, reactive to light, and accommodating. I'm also going to be testing for a direct and consensual response. This is part of the pupillary reaction to light, which is testing cranial nerves 2 and 3, which is optic and oculomotor. So I'm going to get you to focus on a distant object. I'm going to get you to look right here at this while I shine my pen light into your eye. I'm looking for a direct and consensual response. Your pupils go from about a 3 to a 2. Perfect. Okay, now I'm going to test accommodation. Using my pen light, I'm going to hold it about 8 to 12 inches in front of her face and bring it toward her nose. I'm going to have her focus on the object, and this is testing accommodation and then convergence. So, watch my pen light. Okay, so her eyes are accommodating and she went cross-eyed. To test cranial nerves 3, 4, and 6, which is oculomotor, trochlear, and abducens, I'm going to be testing extraocular movements in the 6 cardinal positions of gaze. So I'm just going to ask her to follow my pen light wherever it goes. And this is looking to detect nystagmus.
Five. Okay, good job.
Now we're going to do the cover test. I'm going to ask her to look directly at an object with both eyes, and then to take a card and cover, or her hand, and cover one eye for 10 seconds. And then when she lets it go, I'm going to assess for any nystagmus in her eye as she tries to reaccommodate to the object. So I'm just going to get you to look at this pretty picture here for just a few seconds, and then cover one eye for me. We're going to do this for 10 seconds. Okay, now uncover that eye. And your eye was able to reaccommodate and see everything. It took a second, probably. Okay, so we're good there. Now for the corneal light reflex, I'm going to stand in front of her and shine my pen light at the bridge of her nose, and I'll be looking for the reflection of the light in both of her eyes, and I expect them to be equal. This could possibly detect like a tumor behind the eye, just anything that would make the eyes unequal. Okay, so I see my light reflected equally in both eyes. Now for the ophthalmoscopic exam, I would darken the room. I would take my ophthalmoscope. Let's see if it gets too dark in here. Yeah, way too dark. Okay. So for intensive purposes, I would darken the room. I would turn this to the 0 diopter, I would hold this in my right hand and use my right eye to look into her left eye. I'm going to get you to take your glasses off for this one. Okay, and I would hold my hand just here to balance. I'm looking for the red reflex. I'm also looking at the macula and then the arteries and vessels in her eyes. Okay, so now we're going to finish up the rest of the cranial nerves. We'll start with the trigeminal nerve. This has lots of functions. One is the cornea reflex. This is something we usually test on patients that are unconscious. So we would just verbalize that. We would take a wisp of cotton and brush it across her cornea, expecting to elicit a blink if that reflex were intact. The trigeminal nerve also innervates the face, so we'll test facial innervation using the sharp versus dull test. On several different places on her face, I'm going to do a sharp and then a dull and ask her to let me know which one it is.
Sharp. Dull. Sharp. Dull. Sharp. Dull. Sharp. Dull. Sharp. 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 Dull.
Okay. So her trigeminal sensory function seems to be intact. So for the motor function, I'm going to palpate her temporal and masseter muscles, and I'm going to get her to clench her cheeks to do that. Okay, so that seems very strong. For cranial nerve 7, that's the facial nerve, I'm just going to test motor function of her face. I'm looking for symmetry. So I'm going to get you to puff out your cheeks, raise your eyebrows. You don't have to do it all at the same time. Smile and frown. Good. Okay, so for cranial nerve 11, this is the spinal accessory nerve. I'm just going to get her to shrug her shoulders against the strength of my arms, and I'm going to be assessing her trapezius and sternocleidomastoid muscles. Just give me a shrug. Okay. All right. And then finally, to test cranial nerves 5, 7, 10, and 12, I'm going to assess her voice articulation. So I'm going to ask her to repeat this sentence. The dog chases after the ball.
The dog chases after the ball.
Okay, great. Okay, now on to the neck. I'm going to inspect the neck for color, symmetry, see if I see any abnormal lesions, masses, if I see any enlarged lymph nodes or thyroid nodules. Let's see. I don't see anything like that. So next I'm going to palpate the lymph nodes of the head and the neck. I'm going to start with your preauricular, and you just let me know if you feel any tenderness in any of these. I'm just looking for enlargement on my palpation. Postauricular, submandibular, submental, deep cervical chain, anterior cervical, posterior cervical, and supraclavicular.
No tenderness.
And tonsillar. Okay, so there was no lymphadenopathy in any of those. Next, I'm going to palpate and auscultate her carotid arteries. I'm also going to palpate the position of her trachea and feel for any enlargement or nodules of the thyroid. So we'll start with the carotids. First, I'm going to palpate. I'm going to listen. I'm listening for any bruise. So I'll listen with my bell. Okay. Feel for the position of your everything's midline. And I'm going to wrap my hands around your neck. It's going to feel like I'm choking you, but I'm not. I'm going to palpate for your thyroid. I'm going to get you to swallow for me. And I did not feel any enlargement or nodules of her thyroid. Next, I'm going to observe and inspect for the external and internal jugular vein. In order to do this, I'm going to lay down, and this is around 30 degrees. I'm going to have her face away from me, and using tangential lighting, like my little pin light, I'm going to look for the pulsations of the the internal jugular. And then we know that assessment of the jugular veins does reflect on a patient's volume status. So if they were very large, that could mean that they were in a hypervolemic state. And if they were not seen, that could mean that the patient was hypovolemic. Look for the pulsations. Sit back up. Okay, now on to respiratory. I'm going to start by examining her posterior chest. I'm just looking for any abnormal retractions or bulging when she breathes. I'm just looking for general symmetry here. I'm going to look on her posterior, and then I'm going to look at her anterior. I'm assessing the slope of her ribs. Okay, everything looks good. So now I'm going to palpate, and I'm just feeling for any sinus tracts, masses, other abnormalities, crepitus. I don't feel anything abnormal here. I'm going to do the front as well. I don't feel any crepitus, any masses. Okay. So next, I'm going to assess for respiratory excursion posteriorly and anteriorly. In order to do this, I'm just going to pinch kind of my thumbs together and ask her to take a deep breath and exhale. And this is just looking for any unilateral lag that could be indicative of a pneumothorax, pleural effusion. So I'll do that anteriorly too. So take a deep breath. Okay, good. Everything is symmetric. Okay, so now I'm going to assess for tactile fremitus. In order to do this, I'm going to place the palm of my hand against her back, and every time I touch her, ask her to repeat the words 99. I expect this to be symmetrical. Anteriorly, there may be decreased fremitus over breast tissue, heart, liver. So we'll feel a lot more in the back than we do in the front. And then with COPD, the fremitus could be increased. Consolidation, such as a tumor or pneumonia, it could be decreased as well. So I'm going to just get you to repeat the words 99 every time I touch your back.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, good. So the fremitus was equal, and then pop anteriorly.
99, 99, 99, 99, 99, 99, 99, 99.
And so we did feel a lot more in the back than in the front because of breast tissue, the heart, the liver, the spleen, all the organs. But it was equal, so that's good. Next is percussion. I'm going to be percussing all over, expecting to feel resonance over lung tissue if it's healthy. And in doing this, I'll also be percussing diaphragmatic excursion. I'm going to use a pen. And so when I get her to inhale, I'm going to percuss from the resonance of the lung tissue to the diaphragm, mark it, get her to exhale, and then I will percuss from okay, and then after she exhales, I'm going to do that again and then count the centimeter distance between those two. Normal is 3 to 5 centimeters in a female, and I think 5 to 7 in a male. So first, I'm going to start by just percussing over her chest, expecting to hear resonance over the lung tissue. And I would repeat this anteriorly as well, but just like with the fremitus, there would be a lot more dullness in the front than in the back. So now I'm gonna assess for diaphragmatic excursion. I'm gonna start at the mid-scapular line. I'm gonna get you to take a big inhale for me. You got to inhale and hold it for me. Exhale. And let's do the other side. Inhale big, hold it. Stillness. And exhale. Those are approximately symmetric, and they look to be between about 3 and 5 centimeters, as is appropriate. Next, I'm going to auscultate the lungs. I'm listening for any adventitious breath sounds, crackles, wheezing, rhonchi, anything out of the ordinary. So I'm going to auscultate from side to side. I'm going to get you to breathe through your mouth. This just allows me to be able to hear it better. And I'm going to ask you to kind of give yourself a hug. That'll open up your chest. Okay, deep breath for me. Exhale. So your posterior breath sounds are clear bilaterally. I'm going to listen to anterior as well. Deep breath. Exhale. Do it through your mouth. Through the mouth. There you go. It's so much louder. Deep breath. Okay. And her, all of her breath sounds are clear bilaterally. Last, this isn't really respiratory, it just has to do with the posterior chest. I'm going to test for any CVA tenderness. This is also known as Murphy sign. This is testing for any tenderness over the kidneys. So just tell me if this hurts at all. Any pain?
No. No.
Okay, so now on to the cardiac assessment. I'm going to start with my patient in a 30 to 45 degree angle position, and I'm going to stand at her right side. So I'm going to start by palpating all 5 precordial points. That's aortic, pulmonic, Erb's point, tricuspid, and then the mitral valve. So I'm going to palpate for any thrills or pulsations using the finger pads of my dominant hand. And I'm also going to palpate her apical impulse just using the middle finger of my dominant hand. This is only palpated in a very small area, about 1 to 2 centimeters. So I'm going to go for any thrills or abnormal pulsations. Get her apical impulse, which is at the midclavicular line around the fifth intercostal space. I do palpate that. So next, I'm going to auscultate all 5 precordial points, and I'm going to use both the bell of my stethoscope as well as the diaphragm. I'm going to listen while she's lying down, and then I'm going to ask her to sit up. I'm going to listen again in both of those positions. I'm just going to be noting the rate, rhythm, any extra sounds, and particularly any murmurs. And murmurs are definitely best heard with the bell of your stethoscope. So, listen to you. You can breathe regularly. Now the bell. And I would repeat all of that in a sitting position. Different positions can help you further hear different murmurs. So now I'm going to assess her pulses. I'm going to assess her radial, brachial, femoral, popliteal, posterior tibial, and dorsalis pedis pulse. I'm noting the rate, rhythm, and amplitude. I would do these bilaterally. Brachial. Femoral. Posterior tibial. And dorsalis pedis. Okay, so now we're going to look at the abdomen. I'm going to start by inspecting the abdomen for just skin, general contour, any abnormal pulsations. Sometimes you can see peristalsis. So I'm just going to look over her tummy. I would get at eye level to assess the aortic pulsation and for any peristalsis. I'm going to auscultate her abdomen in all 4 quadrants. I'm going to start in the right lower quadrant, and I'm just noting the character and frequency of her bowel sounds. She has very active bowel sounds. It's lunchtime, so she's hungry. Next, I'm going to listen for bruits of the aorta, renal arteries, and iliac arteries, as well as the femoral arteries. So I'll listen with the bell of my stethoscope. And while I'm doing the femoral arteries, I'll also assess for or palpate for any enlarged inguinal nodes. So I'm going to listen in all those places. First, I'm going to listen with the bell for any aortic bruits. There are lots of bowel sounds. I don't know any inguinal node enlargement. Now I'm going to percuss the abdomen in all 4 quadrants. I'm going to percuss the liver span. I'll start at the midclavicular line below the breast. The normal liver span is about 6 to 12 centimeters. So I'm going to move from the nipple area, from the sound of lung resonance to liver dullness, and I'll mark that with my pen and measure it. Find my pen. I keep using my pen. We'll just verbalize it. So I'm going to start below the nipple line. I'm going to percuss down. There's lung resonance. Okay, there's the liver dullness, and so that's measured at around 6 to 12 centimeters. Now for abdominal reflexes, there's an upper abdominal reflex and a lower abdominal reflex. I'm going to stroke the abdomen toward the umbilicus, and I expect the umbilicus to deviate toward the stimuli, whether it's from the bottom or the top. So her abdominal reflexes are intact. Absence of these could indicate a pyramidal tract lesion. Next, I'm going to palpate. I'm going to palpate the abdomen lightly first and then more deeply. And when I'm doing my deep palpation, I'm looking for internal organs. For example, the liver, the spleen, the kidneys. So I'm going to start with the light palpation. The light palpation is really just feeling for any tenderness. Let me know if you feel any tenderness, any masses, abnormalities. Her abdomen is non-distended. And so now I'm going to use deep palpation to palpate for the liver. I'll only usually be able to feel the lower border of the liver. So I'm going to get you to take a deep breath in for me. Exhale. Okay. While I'm over here, I'm going to feel for the kidney. This isn't usually palpable unless it's very enlarged. And now for the spleen. Deep breath in. Exhale. And I do not feel the spleen, and I should not feel the spleen unless it's 3 times its normal size. I'm also going to palpate for the aorta by pressing firmly into the mid-abdomen. Okay, now I'm going to percuss the liver span. I'm going to start at the mid-clavicular line around below the nipple area. I'm going to percuss down until the sound changes from lung resonance to liver dullness, and then I'll start around the level of the umbilical, coming up until it changes from to liver dullness. Okay, so I mark with my pen there. And mark there. And I expect the span to be between 6 and 12 centimeters. Okay, so now we're going to be assessing musculoskeletal and extremities. I'm going to start by inspecting the arms and the legs. I'm just looking at the skin and muscle mass, hair distribution, and venous pattern. So I'm going to just look over your arms. You don't have much hair on your arms. That's nice.
Never have.
Looks like appropriate muscle mass. And look at your legs. Looks like appropriate muscle mass. So next, I'm going to assess capillary refill in the fingers and the toes. We expect capillary refill to be less than 3 seconds. So it's a very quick capillary refill. Okay, so less than 3 seconds by far. Now I'm going to assess her arms and hands, feet, and legs with the pain sensation, or the sharp test, vibration sensation, and light touch. So we're going to basically do sharp versus dull again on her legs, and then we're also going to test vibration sensation. So I'm going to get you to close your eyes and tell me whether you feel sharp or dull.
Sharp, dull, sharp, dull, sharp, 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 dull, sharp, dull.
Okay. And the feet are really most important. We know that we have a lot of patients with diabetes, peripheral vascular or artery disease that have just decreased sensation in their feet. So, can you tell me if it's sharp or dull?
Sharp?
Is it tickle?
Yes. Yes, it's ticklish. Dull. That's sharp. Dull. Sharp. Dull. Sharp. Sharp. Sharp.
The pinky harder.
Dull. 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 Sharp. Sharp. Dull. Dull. Sharp. Sharp.
Okay, perfect. Next, I'm going to assess diagnosis by giving her an object and asking her to identify it. I need you to close your eyes. I'm going to give this to you in your hands, and you tell me what it is.
It is an ink pen.
Perfect. So, next we're going to assess the rapid alternating movements. I'm going to get her to follow my finger in the point-to-point test. So, I want you to go from your nose to my finger. Like, okay, to your nose, and back to my finger. This is rapid alternating movement. Okay, wonderful. Now I'm going to assess your deep tendon reflexes. I'm going to do the biceps, the triceps, brachioradial, patellar, Achilles, and Babinski. I'm going to go ahead and pull this closed. Get my reflex camera. Where's my reflex camera? Oh, here it is. Okay. So I'm going to start with biceps. I'm going to palpate the biceps tendon in the AC. And I'm going to put my thumb on that tendon, strike my thumb, and I'm going to expect a palpable flexion at her elbow. So I'm going to get you to just relax your arm here. I'm going to open that. Very palpable flexion. Is that right?
Mm-hmm.
That's cool. Okay. I'm going to do the other arm as well. I can't do that one. Okay. Oh. And next I'm going to do the triceps. I'm going to flex your elbow at 90 degrees, like this. And I'm going to strike just above your elbow. I'm expecting palpable extension of your elbow. You can relax your arm. Good. Okay, so now the right side. Well, this is just a slight extension. Okay. And then for the brachioradial, I'm going to strike the tendon about 1 to 2 inches above the wrist. Expect flexion of the elbow. Just right here, just relax your arm. And that's a very slight response as well. Now for the patellar reflex, I'm going to get you to relax your legs. This is the one we all enjoy. And straight. There we go. Both sides. Wonderful. Now for the Achilles reflex, I get you to flex your foot and strike just above your Achilles. And this is just a really slight dorsiflexion of your foot. Okay, now finally the Babinski reflex. This is an abnormal reflex except for in very, very young infants. I'm going to use my reflex hammer, come up your foot and across the balls of your toes. If it's present, your great toe will flex and your small toes will fan out. So really it should just tickle.
Tickles.
There's no Babinski reflex here.
Just a tickle as
I'm going to palpate your epitrochlear node in your arm right here for any enlargement. Now I'm going to finally test the muscle strength in the upper and lower extremities. Okay, so I'm going to get you to lift up and get some moves. Okay, back down. Out. And in. Okay. Lift up. Oh gosh, okay. Down. Out. And in. Okay. Appropriate strength. Okay, now for range of motion, we're going to kind of do this one together. We're going to start with the neck. So we're going to do flexion, extension, lateral side to side, and rotation. Now for the shoulders, you always want to inspect and palpate the joints before you ask a patient to perform range of motion. So I'm just going to inspect and palpate for any obvious deformities. For your shoulders, I want you to do abduction, which is raise your arms out to the side and overhead. We're a little crammed in here. Adduction. Just cross your arms in front of your body. Flexion. Of both sides, I guess. Hyperextension. For internal rotation, we're going to place our hands behind our back and touch our shoulder blades. And then external rotation is our hands behind our head. Now for the elbows, I'm going to inspect and palpate your elbows, making sure I don't note any obvious deformities. And we're going to do flexion, extension, supination, and pronation. Hands and wrist. And look at your hands and wrist. Okay. Flexion of the fingers, make a fist. Extension and abduction. Flexion of wrists with palms down, point your fingers toward the ground. Extension. Ulnar deviation. And radial deviation. Okay, now for the hips. Do you have any deformities in your hips?
Not that I'm
Those are a little harder to inspect. So we're going to do abduction, which is away. Adduction. Flexion is kicking your leg forward. Extension is kicking your leg back. internal rotation, you bend your knee and kind of twist it to the center. And external rotation, you twist it out.
It's kind of hard.
And you would do that on both sides. And then for the knees are real easy. It's just flexion, you bend your knee in. Extension, you extend it. And both sides. Now let's do our ankles and our feet. There we go. Put them under there. Okay. We're going to do dorsiflexion, so we're going to point our foot towards the ceiling. And you would allow your patient to hold on to something as well. Plantarflexion, point your foot toward the floor. Inversion, bend your heel inward. And eversion, bend your heel outward. You would do that on both sides. Now for the spine, I am going to inspect and palpate her spine. Get you to go this way. I was able to visualize your spine earlier with the posterior chest. I don't feel any kyphosis, lordosis, scoliosis. If scoliosis was suspected, I would do the bend over test. But for the range of motion, I'm going to get you to bend forward and try to touch your toes. Okay, good. Okay, now bend back as far as possible. Okay, good. That's enough. Lateral bending, bend side to side at the waist. Okay, and then for rotation, you're just going to rotate from side to side. Okay, now for the Romberg test, I'm going to get you to look at me. I'm going to get you to close your eyes and put your hands out like you're a zombie out in front of you. There you go. And I'm just noting for any swaying. This has a lot to do with your balance and vertigo, and I don't see any swaying in this patient. And finally, I'm going to assess this patient's gait. We're going to do normal walking and then heel to toe walking and then walking on tiptoes. So I'm going to point this downward again, and I'm going to get you to walk just from here to here regularly. I don't notice any disturbances in your balance, and then walk back heel to toe. I'll be here to catch you if you fall. Good job. And then if you could just walk back on your tippy toes for me. All right.